We have had interesting topics. We have had interesting topics over the years now. And this month we have the opportunity to invite Dr. Salcedo, who is a geriatric psychiatrist and who runs the a geriatric psychiatric program in Skyline Madison campus. She has gracefully accepted the invitation. She had her MD from American University of Antigua College of Medicine, and she did general psychiatry in East Tennessee State University, where she was a chief resident. She went to Vanderbilt to complete geriatric psychiatry fellowship, and that's how we recruited her for our program here in the Skyline Madison campus. She has a lot of interest in dementia, impairment, caregiver issues, and psychological issues of aging. And we wanted to ask her to explain to us about preventable aspects of cognitive impairment and also protective factors, and maybe what's coming in the future and how to improve our well-being, both mental well-being and maybe prevent some cognitive impairment. And welcome, Dr. Salcedo, and podium is yours.
All right, thank you, Dr. Billiard, and thank you all for having me speak on this topic. As Dr. Billiard just mentioned, this is something very near and dear to my heart, but certainly I didn't know how to kind of, base it, because I know that we've got some doctors on here as well, and so certainly some might be I prepared it essentially for the general public, so some things to kind of pick up on that. So I'll go ahead and get started there. So essentially here, so cognitive impairment, just a general topic. I'll go over kind of the differences of at least how I diagnose here when we have folks coming in on the inpatient setting. So kind of ways to recognize it, and essentially tips on minimizing risks. So I'll go ahead and move forward here. And I have zero disclaimers there, so no, I guess, conflicts of interest or anything as such. So, all right, so I'm going to go ahead and start with what is normal aging. So essentially, part of it, it's something that happens. So essentially, the way we can help differentiate is nothing's really interfering with our activities of daily living. And I'll go over a little bit more in detail for that. It doesn't interfere with our ability to learn new things, nor does it interfere with any of our independence. Part of it with that as well. Now, as far as part of normal aging is there is a slowing of mental processing. I guess the best way sometimes I describe this is, with driving, sometimes reaction time might be affected. It doesn't mean that's dementia. That's, certainly parts of things, that does occur with normal aging. So just some basic, ways to kind of differentiate between the two. I'll go over more in detail on that. So here, just kind of defining what are ADLs, or the activities of daily living. Essentially, these are the things that we do on a daily basis that we don't even think about. But within geriatric psychiatry, it's a big part of how it helps me kind of figure out what level of memory or cognitive decline the patient might be in. So typically, if they're able to bathe, take care of their hygiene, toileting, dressing, eating, ability to walk and ambulate without, even if there is a need for a walker and such, all of these things usually remain quite intact. When it comes to, with normal aging, and certainly more on the mild cognitive impairment range. So all of these do remain intact. Now, when they start to get affected, as I'll talk a little bit more later, certainly that's when we start to kind of do a little bit more research on what else is going on at home. Another thing that we do evaluate is the instrumental activities of daily living. So this is just, more so in the sense of, can I still go grocery shopping and cook the food? Or am I burning the food, the pots, things like that? And certainly administering medications to myself. Am I able to still drive? Finances, that's a huge thing. When we start to notice that, one of the questions I would always ask family members, are bills getting, are they late? Are we falling behind on rent, mortgage, what have you? That gives us an idea whether or not the finances are starting to lag. And with regards to just really kind of keeping up with the household. So a lot of those things we look into with the IADLs as well. So. And here, so essentially I just kind of, put into columns there, the normal age-related memory changes, as you can see there on your left. So independence is going to be a huge thing, being able to still continue to do things independently, with maybe some occasional memory lapses, but nothing certainly that will interfere with function. Still able to recall and describe incidents of forgetfulness. So we all forget, things here and there, but if we can circle back and come back to it, it might be just other factors. It doesn't necessarily mean it's dementia. Certainly, maybe just pausing for directions, even if, you might pause, but you're not getting lost, especially driving to familiar places. And then certainly word finding, I think to some degree, a lot of us kind of like, what's that word I'm thinking of? That occasionally can happen, but essentially that'll come, back to you relatively quickly. And certainly judgment and decision making. And so with regards to what might indicate dementia, as you can see on the right, essentially it's kind of the breakdown of what I was talking about earlier with regards to the ADLs and IADLs, difficulty performing all of these tasks. And so when we have folks coming in, the family members are crucial in being able to kind of let us know what the progression of the cognitive decline may be, be it has it been progressive? Is it stepwise in nature? There's different ways to be able to differentiate what type of cognitive impairment we're dealing with. So as you can see, again, just kind of a breakdown, but essentially the function is really the key feature here, that if functions start to decline and others have had to step in, that's essentially when we're starting to look in that realm of more so, a little bit more than that mild cognitive impairment, but maybe more so dementia. So I broke down the different cognitive domains too when I evaluate, each individual. And essentially these are the portions that are also evaluated in the MoCA. I noticed on the flyer that you all sent out, I like that drawing that you had found, because this is really kind of the breakdown of what areas of our brain allow us to move forward with our activities of daily living. So complex attention, executive function, planning things out, making sure I can still, be able to, like pay for the bills, different things like that. Learning and memory, kind of the basic things, one of the things that we first tend to see. Language, we'll see that more so kind of in the later stages if we see any decline with that. I've certainly had, folks who are much more advanced that they regress back, so to say, not regress, but return back to their native tongue where they can no longer speak English. And, so that's, kind of gives you an idea of the progression. Perceptual motor, kind of like what I was talking about with driving, maybe not able to brake as quickly as we could. Some actual motor type skills are affected. And the social cognition, so more so kind of what's acceptable within society when that frontal lobe goes. Certainly there's a lot less control, and that's when we start to see some personality changes. So these are the main cognitive domains that some of our memory testing or memory screening, I should say, like the MoCA, the Montreal Cognitive Assessment, is the one I really like to use here in the hospital because it really is a lot more sensitive for actual mild cognitive impairment. It doesn't do too much with dementia, but the reason I find that to be very helpful is that's the stage that we need to be able to hopefully start treatment should the individual want that, because that's unfortunately our medications, that's where we're at. It's really, we have to treat at that mild cognitive impairment or mild neurocognitive stage in order for it to be even effective. So these are some aspects of the testing that, I would evaluate on the individual. Okay, so here, this is just kind of a breakdown. Our Bible, as Dr. Billiard knows, there is our DSM-5. And so within DSM-5 and diagnostic criteria, it's essentially mild versus major when it comes to neurocognitive disorders. And so in this breakdown with the mild cognitive disorder, so you can either hear it as mild cognitive impairment or mild neurocognitive disorder. Those are synonymous. And so essentially with that, there might be that modest decline, but it's essentially more on the mild component where individuals can still very much operate independently. And so with the mild component, this is kind of what we're looking at, where you might see just some impairment, but generally able to still carry on with their day-to-day activities. But when we switch over to major, certainly a lot more of the IADLs that I had mentioned earlier, and it crosses over to your ADLs when it gets to that major neurocognitive component, because at this point, the individual might actually have difficulty bathing or might have difficulty dressing because there is some of the cognitive lapse. And so that's why you'll see a substantial impairment. So essentially that's where the major neurocognitive diagnosis comes into play. There's other things that, I would look at, be it, head CT, MRI, PET scan, that might give us a little bit more clinical, on top of the clinical symptoms, I should say. But ultimately, this is where we're now going into the different type of dementias when we're saying the major neurocognitive disorder. And I guess I kind of talked about this already. Essentially, mild does not interfere with our independence, versus major. Obviously, that's where we're requiring a lot of assistance, be it paying bills, managing medications, ambulation, different things like that. Okay, so these are, this is not an exhaustive list. Unfortunately, there are far more than this list right here that you can see. So we've got numerous types of dementia, and I feel like it would be a whole different lecture to even talk about all of these. And so I just wanted to highlight Alzheimer's, of course, since that's our most common. But the top three is commonly what I tend to see here. Lewy body disease or Lewy body dementia is a lot more common than we once thought it was. And certainly frontotemporal is starting to kind of creep up there in our younger population. So, but what I do want to kind of focus on more so is Alzheimer's, just because this is about 70% of our population, anywhere from 60 to 80 is kind of the range where of the folks who have dementia, oftentimes it is Alzheimer's disease. Okay, so just a little backdrop. Everyone always talks about Dr. Alois Alzheimer's. So really the coining of the term was more so in the earlier parts of, later parts of 1800, early 1900s, where, he started to describe this type of senile dementia with his first patient in 1901. And it always strikes me because she was only 55, at that time, but that was one of the first patients, that we had seen some of this evidence. And typically we wouldn't see that until autopsy. So we don't really know for sure. We just go with the clinical picture. So as I mentioned already, most common cause of dementia in the elderly is Alzheimer's disease. And essentially this one is just very progressive on onset. So it might be, gradual initially. There's some dips at times, because oftentimes you'll see Alzheimer's and maybe a vascular dementia where there's a mixed picture. And so the pattern is really helpful with the diagnosis. But here, mood is also something that gets highly affected. And of course, within psychiatry, where we're always treating depression and anxiety. But with Alzheimer's, there's an apathy, essentially, that presents itself and really important to treat alongside of the memory decline. And so the common mechanisms, or at least for what we know right now, what is this? What's building up in our brain? And so really these two proteins have been in the books for quite some time, be it just the aggregation of amyloid beta versus the tau protein, the hyperphosphorylated tau. So these are just, pictures of the actual structures that interfere within, our axons essentially in our brain. And so there's lots of theories in the sense that I'll kind of go over in a little bit, that the amyloid beta is kind of clogging up, so to say, as well as tau. And these two components are important to bring up because it's essentially how we try to research, well, what would be a good medication to help with treatment? Because right now we've got the main medications that we have are purely to help with symptoms. There's nothing so far right now that's disease modifying until the most recent finding, which I'll talk about, that just that became public in June of just last year. So I'll talk a little bit more about that. So these, again, are the two main proteins that we see that aggregate. This is all, of course, on autopsy, but those have been the theories behind Alzheimer's or just dementia as well. And so in comparison, I apologize, that's a lot more blurrier than it was on my end. But as you can see on the left, the healthy brain, not as much atrophy. You can see the ventricles are what we would consider normal size, versus here you can see a pretty significant atrophy and enlargement of the ventricles. Now, enlargement of the ventricles certainly is not pathognomonic or anything for Alzheimer's, but one of the things that you would easily see on head CT even. And as you can see, this is those amyloid plaques and the tangles that I was talking about earlier that can build up within this region. And essentially the hippocampal area right down here is where we tend to look. So that's more of a diagram, but the actual pictures, I've always used this even throughout training. This is, of course, a very significantly atrophied brain and shrinkage of the hippocampal area. And so just visually, these are, kind of the pictures that you would see with regards to what's a healthy brain versus a brain that might have that cortical atrophy, as well as enlarged ventricles. Okay, so I wanted to actually, my husband helped me with putting the video in here, but for some reason it disappeared when I was practicing it. But there's a really great video on the Alzheimers.org website that I usually like to put in this lecture. But essentially now, since I've started to do this, or at least the start of my training, which hasn't been that long ago, it was only 6 years ago, but it's already risen in that time. At that point, when I first presented this, it was 5 million Americans that are living with Alzheimer's. And as you can see in just that time frame now, we're at 6.2 million, actually is the latest fact that I had just seen. So we're looking at by 2050, not too long from now, that we're nearly over doubling this number. So it's really quite astounding. And as we all know and have felt in this last few years now, within this past few years, the deaths have increased, unfortunately, and it's 16% was what I found on the website with regards to COVID. And I believe a lot of that, as we've all been feeling, is the isolation. It's already an isolating disease in itself, but here not having that social interaction, we've certainly seen quite a decline. And a lot of folks that would typically not even be in an inpatient setting. So, this really rings true, at least from what we're seeing. And this is the part that always scares me. 1 in 3 seniors will die with Alzheimer's or some other form of dementia. That the rates are pretty astounding, that it kills more than breast cancer and prostate cancer combined. And as we know, those two are the most common cancers we see in our women and in our men, but we're seeing more and more of this. So something has to be done, with this, and how can we actually, if possible, slow the progression. In 2021, the cost that it has had on our nation, $355 billion. And as you can see here, rising back to about 1.1 trillion. So really a lot of this also has to do with, family members. I'm sure all of you have known or may be experiencing it now, that, cannot work and stay at home with our loved one, and really kind of the loss of income. And, as far as what that has done too, that really we need to come up with better solutions to be able to support these families. They're in the sandwich generation per se, is what we call, where you're helping your parents, but then you're still raising your children. So there's, a lot of those components socially that, really needs to be evaluated. And like I mentioned before, really the unpaid care, 11 million Americans are providing unpaid care for folks with Alzheimer's or other dementias. And this last point here, so in less than 20 years, between 2000 and 2019, the deaths from heart disease have decreased 7.3%, which is excellent because our cardiologists are obviously, getting it right. We're seeing a decrease there, whereas as you can see here from Alzheimer's, it's actually increased by, and that's not 14.5%, guys, it's 145%. And it's also because we're aging, right? We're living longer, so we're going to be seeing more and more a lot of the folks who do have or develop dementia. So pretty much, in speaking with Dr. Villiar, earlier too, trying to find out what can we do to prevent it, right? And, I don't want to burst anyone's bubbles, but prevention, we really don't have anything that can prevent it. Now, we can actually modify the risk factors. And so really the ones that you can see here, age, family history, and genetics, those two I put on red. We can't change that unless someone finds a fountain of youth. You let us know. You'll be very rich. And so, but age is, unfortunately, that's the #1 risk factor when it comes to developing dementia. And of course, like I mentioned, family history and genetics, lifestyles and or lifestyle modifications, cardiovascular health, social and intellectual activity, insomnia, sleep apnea, depression, and medication. So these are ones that I highlighted. Certainly there's a few more out there, but if we can at least try to modify this as a society, we might be able to see, a decrease or, in essence, kind of minimizing these risk factors. So all of the ones in green are modifiable. And so that's where we have the most hope and where we, at this point in time, can focus where we are with treating our folks. So with regards to age, like I've already said, it's the greatest known risk factor. And to emphasize that Alzheimer's is not a part of normal aging. So really with that, it's just age in itself, because starting at the age of 65, the incidence of Alzheimer's doubles every 5 years. So at the age of 65, it's the 5% chance of getting or dementia in general, but by the age of 70, that doubles, and in the 75, it doubles. So that's essentially where age is really the main risk factor. Okay, and so with regards to family history, so I'll move on to this portion here. So most of the cases of Alzheimer's are pretty sporadic. There's not an actual genetic tie for most of the cases. Now, of course, there's the rare cases that I'll go over in a little bit here, but as you can see here in the next feature, it does develop in about 20% of patients' offspring. So certainly having Alzheimer's as a family member does affect to some degree, about 20% increased risk and 10% in second-degree relatives. Trisomy 21 or Down syndrome, and I'll go over here as far as the gene that they possess also increases that risk. Essentially for folks with Down syndrome, usually by the age of mid-40s, you are already seeing development of Alzheimer's. So they have a very high risk of Alzheimer's disease. And possessing the APOE4 gene that I'll, like I said, talk about here in a little bit. And so here, the genetics. So there are deterministic genes, as you can see, and they tend to develop in folks when they're younger than 65. And so as early as 30. The earliest so far that I've seen when I was over at Vanderbilt, this patient was only 45. And so when you're seeing folks, come in at such young ages, they have teenagers, they're still in the kind of, height of their careers. And so it's pretty devastating. And so there are certainly ways to be able to detect it. But at that point, it almost becomes kind of an ethical, kind of dilemma. Do I want to find out if I have a higher risk versus do I just, kind of wait and do what I can? Okay. So the APOE, the epsilon 4 gene, that's what I was talking about earlier, that's what actually carries the blueprint. So from what we know from a genetic standpoint, this is the lipoprotein that we can detect that might increase that risk of getting Alzheimer's. And so, with these, it's what you inherit, from your parents, essentially. So with these forms, E4, the epsilon 4 variant, that's going to be the one that we see with regards to that. But as far as you can see here, the epsilon 3 and 2 and 4, are a little bit less common with that. So in essence, that's one of the things that is evaluated genetically with it. And oftentimes you'll be able to, obtain this from CSF, just with further testing. All right, so again, E4 increases the risks, and whereas as far as E2, there actually is a little bit more of a protective sense to that. But again, we can't pinpoint that, but maybe in the future we might be able to isolate those genes, who knows, and kind of see if we can decrease in that way. But I think that's in the pretty distant future. All right, so the lifestyle modification. So a big chunk of where we can really make a difference in helping, prevent or minimize the risks of this, because, this isn't anything new. This is, as physicians, this is what we essentially have always counseled our patients, exercise, make sure you stop smoking, minimize your drinking, control diabetes, hypertension, cholesterol. So that hasn't changed. So that is also the same case here with Alzheimer's. So, one of the things I mentioned, Dr. Petrie earlier, my mentor, he always recommended get at least a mile a day. We're not saying work out for 2 hours. It doesn't have to be that intense. But if we can stay active, that has made a tremendous difference for folks. And certainly, of course, you've got to be creative in case ambulation is difficult. But all of these components, as I'll go over in a little bit, if we can even just minimize all of these with treatment, we can really see some improvement. So as far as, the regular exercise, the recommendations, with that, if we can exercise 30 minutes a day, 5 days a week, that's generally kind of the recommendation there. And with regards to the diets, I'll go over a little bit more specifically about the Mind Diet in a little bit here. So as you can see here, this is a little dated for 2012, but nothing really has changed as far as what we're seeing, where the fastest cognitive decline has been observed in obesity and folks with metabolic syndrome. So for those are the folks who've got diabetes, high blood pressure, dyslipidemia. So much higher rate for those folks. So I wanted to kind of dig a little bit more with Mind Diet, or the Mediterranean DASH. So it's a combination of, we've all heard of the Mediterranean diet, where you're trying to get more fish throughout the day, olive oils and things like that. And then with DASH, with regards to actually trying to modify or stop hypertension. So those two diets have been mashed into one, calling it the Mind Diet. So, as an intervention for neurodegenerative delay. So that's what Mind stands for. And very plant-based foods. So I think everyone's really been seeing plant-based has been the way to go. We're seeing a lot of that, where we're limiting red meat, saturated fats, and sweets. So essentially here, the diet itself, as you can see, can reduce that risk by 53%. Or at least slowing that decline. So I'm going to show you here in a little bit what the Mind Diet entails. But the green leafy vegetables, that's great. That's really one of the main things to emphasize, in berries. So when we talk about eating fruit, it's not bananas, it's not mango, although of course that would be amazing because I love mango, but it's berries, so blueberries, blackberries, those are the ones on that list that actually can help reduce that risk of Alzheimer's. And so this is just a little list. Actually, you can find this on the Mayo website. And so, and just kind of looking at this, you guys look at it and see if you can give yourself a point for each of the features. Do you eat at least 3 servings of whole grains a day? The green leafy vegetables I was talking about, do you have that at least 6 times a week? Okay, berries at least 2 times a week. Vegetables at least once a day. Red meat less than 4 times a week. Fish at least once a week. So this diet is a little bit more conducive to the American diet. It's not as restrictive per se as the Mediterranean and the DASH. And so, but nonetheless, as you can see here, the emphasis on, minimizing the red meats and getting the vegetables, minimizing fried or fast foods, mainly using olive oil. So it's really a combination. So in each of these, points, if you can tally it up, if you scored about a 9, you're doing all right. Okay, so you don't have to have all 15 of these, but because I've got multiple best friends who are Indian, I am certain all of you guys are eating your vegetables. Okay, so at least I know with that, with this, I mean, it's really astounding how helpful the diet can be. And everyone always asks about wine. Okay, so certainly the 1 glass of wine a day is, what's on there. Now, if you're not a drinker, it doesn't mean you have to start drinking. But at the same time, too, I always kind of, I'm cautious about that, because sometimes even 1 glass of wine a night, well, as our metabolism changes, that might also, so that one is, up to everyone's kind of discretion, but certainly it can have some of those cardiovascular effects similar to like NICE and things like that. So here, as it's been laid out in the Mind Diet, what's really great to see is, those who actually in the studies that were done with the Mind Diet, you can see that the people who had actual brains about 7.5 years younger compared to the control. So it's a huge difference, as you can see. And then it even has said that there's a delay in dementia by 5 years. And delaying dementia just by 5 years alone can really cut our prevalence in half. So, just with this type of diet and keeping in mind that, this is what we can do, like I mentioned earlier, an average score of just 9.6 points is what shows the biggest drop in Alzheimer's risk. And so really with this, these are some pretty substantial numbers, and so really worthwhile trying to observe the Mind Diet. Okay. So the other component that we can alter or, modify is social and intellectual activity. So when I, of course, presented this, there was no COVID. And so now I know this has really been our biggest challenge. In essence, not being able to socialize. I come from, just kind of having that family structure that it's loud. There's lots of people always around. But now with having to, just really quarantine or just really minimize that interaction, we've really seen a huge difference in decline with folks who already have had a mild cognitive impairment. And so really, social interactions, which is great in communities like ours who are very family-based and oriented, it has made it a challenge these days because of, COVID. One of the things I did want to highlight, though, I know I mentioned earlier when we were talking that, dementia doesn't discriminate. You could have MDs, PhDs, and, all of this, and it can still affect you. However, having a low education level or less than a high school education can actually be considered a risk factor. And in essence, those who are, just always studying or always, using our mind, it's exercise. And oftentimes what I'll see here are the folks who, have had, high school degrees and beyond, certainly have fared better in the sense that they're able to almost, I don't want to say mask, but they can compensate essentially a lot of decline. And that they are able to function longer independently than, let's say, somebody who might not have had the same educational level. And the other part that I really found interesting is the lifelong bilingualism that actually may delay the onset of dementia by almost 5 years. So, when I read this, and I remember being a child, being born in the Philippines, coming to the States, and parents still speaking Tagalog, that's our main language, to us, and we're like, stop speaking it, just speak English. I'm so thankful. So Mom and Dad, thank you for forcing me to be bilingual. So that in itself right there, for most of the people I'm sure on this screen, that's another savior there for us. So even learning a new language, and we'll go over more of that as well. Those are some ways to be able to minimize our risks. Okay. So occupational attainment, I highlighted that and I put that kind of towards the end because, what we're seeing more and more so is with retirement. I know that that's what everyone aims for. I'm going to get to retire. I'm going to get to travel. I'm going to get to do all of these things. And then we get COVID. So a lot of folks who, just hit retirement are now, what are we going to do? And so there's some evidence that early retirement is also a risk factor. So keep that in mind for those, who love their jobs. Don't retire. Just keep working as much as you're able. Work part-time, keep going. And so as you can see here, some of the studies that, I had found in data of over 20,000 older Americans, they estimated that if people waited until after the age of 67 to retire, just overall cognitive health would benefit. And with this and delaying that, you're able to really maintain that sharpness, making sure that you're always thinking, and again, that mental exercise, so to say. But as you can see here with folks who retired a little bit earlier between the age of 61 and 67, they have been able to, if you can just delay it, we can really reduce the risks, or at least that's what the numbers are showing. So, again, early retirement, not necessarily entirely great, but if you do retire early, you just have to find something else to do, something else to find that purpose. And I think purpose in itself is crucial in being able to continue to function, and be happy, because that's really, ultimately what we want to strive for. Okay, so this is just more information that the research team had found that it can really find benefits even beyond 5 years, in essence, by continuing to work at least at that age, beyond 67. And here even earlier retirement was linked to a faster cognitive decline. So, so there is some evidence, that is being seen, or studies that are being done on this. And, and even seeing on the inpatient setting, just this is more anecdotal, but even over at Vanderbilt, I would get a lot of folks who are admitted inpatient and have never had any inpatient psychiatric hospitalizations before. And a common pattern I was seeing is they just recently retired. I'm not trying to scare anyone. I'm just trying to say, when you do retire, find other ways to, certainly fill your time. All right. Now, I do want to talk and gloss over a little bit on insomnia. So this is really important. And with regards to studies that show links or associations with just essentially risk of all different types of dementia, as you can see here. So pretty strong power with regards to some of these studies. And there's newer studies, out as well. On that. But with regards to insomnia, the theory, it takes us back to that. Remember, I was talking about the amyloid beta. And so with insomnia, folks who are just not getting, who are getting less than, let's say, 5 hours of sleep, it plays a huge role in actual clearance of this beta amyloid in our brain, sleep. So in theory, or at least what these studies have been showing, is if we're not getting enough sleep, we're not allowing our brain enough time, the glial cells, essentially to clean out this beta amyloid. Then, of course, kind of based on what I was talking about earlier, as the protein buildup, then it just continues to build up. So insomnia has been seen to be a risk factor. And so really, if that's something that you suffer from, making sure, different efforts with regards to sleep hygiene, is a great place to start. Or maybe with melatonin, or discussing something with your doctor as far as how can I help, relieve this insomnia. And so really with that, the numbers, or I was looking up the actual hours. The recommendation is, of course, if the person's getting at least 5 hours, anywhere to about 7 hours is considered good in that stage. Anything less than 5 hours is a risk factor, and actually anything greater than 10 hours of sleep is also a risk factor. So it's really finding that sweet balance in between to give the, you know, the glial cells, or our cleaner cells, so to say, to clear out this beta amyloid while we're resting. And so this is just more information, kind of what I've already kind of talked about there, where I was saying about 5 hours and greater than 10 hours are actual, you know, risk factors. So make sure you're getting anywhere between that 5 to 7 range is really what the studies have been finding. That's going to be the most beneficial. But what was also interesting down here, so participants who did have less or shorter deep duration sleep, but had high physical activity, there was actually no greater risk of dementia for them. So, you know, in that study, at least, you know, seeing how physical activity can almost negate the drop in, you know, in sleep. So, because I know there's plenty of people out there who are probably sleeping less than 5 hours and can still function, but I almost guarantee you they're quite active in essence to be able to keep up with that. Okay. And I did want to bring up sleep apnea as well. So any sleep disordered breathing has been associated with all-cause dementia as well. I know when I was over at the VA, one of the things that we did in an outpatient setting is we didn't even really do the outpatient follow-up until the sleep apnea was corrected. Because oftentimes what we've seen with a lot of the veterans is when they've been dealing with obstructive sleep apnea or central, you know, sleep apnea, different components there. Once that can be corrected, oftentimes what they'll see is the cognitive decline has improved. And what I mean by that is, you know, with regards to concentration, word finding issues, you know, certainly can be or can present when someone has sleep apnea. You know, they're feeling exhausted and tired. And so a lot of the meta-analyses that I did, you know, in my research there for the sleep apnea did suggest that the sleep disturbances, you know, risk. So definitely worthwhile really trying to push through. If you're using a CPAP, keep using it or find the right fit because it really can make a difference. And so here, you know, as you can see, just in over 3 years, just the suggestion of the positive airway pressure is very helpful in minimizing the risk factors for dementia. All right, so depression. So this is kind of, you know, our meat and potatoes essentially within psychiatry. I mentioned, of course, too, with dementia alone, there's the apathy that's also involved. But here with depression, it's almost prodromal, or some of the symptoms that we tend to see before actual diagnosis of Alzheimer's disease. So very important, and that's why, you know, pretty just, you know, vigilant here to be able to treat folks who present with dementia. And there's also even an anxiety component that I've seen also with folks that have no explanation where the anxiety is coming from, but then it ends up being almost prodromal to some symptoms of cognitive decline. And so here, as you can see, so major depressive disorder can also accelerate the brain aging. With regards to like DNA methylation and increasing cortisol. And so what this portion of, you know, the research I found, depression and really the effects of cortisol in our body. So when I think of cortisol, you know, we all just think about the stress, right? The stress that we are put through in life and such. And so the correlations there are really pretty substantial, at least in a lot of these clinical studies. And so in cognitively healthy subjects, higher cortisol levels have been actually associated with that increased risk of cognitive decline. So that's where mindfulness, you know, comes into play, meditation, yoga, a lot of things that can help us be more centered and minimizing, you know, our cortisol levels, you know, certainly has that association. And down here, subjects with dementia and mild cognitive impairment due to Alzheimer's have been found to have higher levels in our CSF and our in our brain essentially than the cognitively healthy controls. So really important to help minimize that. And I think I may have just repeated that part up here. But nonetheless, really the bottom line is, treating the depression, certainly, but also treating the causes, and also the portions that contribute to depression will be very important. Okay, they're gonna go over real quick about some medications that can also predispose us to have cognitive decline. And histamines are notorious. So even Benadryl, you've got to be careful about taking Benadryl or any allergy medications, essentially, as the anticholinergic components for that can, predispose some cognitive impairment. Benzodiazepines, I can't emphasize enough. Unfortunately, I get a lot of folks who come in and they're on Xanax 4 milligrams total a day for the past 30 years. No matter how old they are, certainly that and the way all of these medications, essentially kind of like your Ambiens or opioids, their goal is to kind of actually dull our experience, so to say, our experience of anxiety, our experience of pain. But that's all essentially in the same pathway as our cognition. And so all of these in general, anti-seizure medicines, Topamax, notorious for causing a lot of cognitive blunting, word finding issues. TCA antidepressants, because they have a lot of anticholinergic properties. Beta blockers, I know, of course, we need that, but at the same time, with blood pressure, again, kind of where beta blockers and statins, there are correlations there as well. Now, I put these kind of two in the bottom because obviously they're there to help treat cholesterol problems, for instance, but with statins, higher doses or longer prescription of this sometimes, because we do still need cholesterol because our brain is just fat. And so that's essentially kind of the theory behind statins and how that might also be associated with some cognitive decline. So I know that's just kind of brushing it over because I'm not sure how I'm doing on time. But essentially, those are some common medications really that, we should caution our loved ones to stay away from if we're seeing a cognitive impairment already. All right, so current treatment, so non-pharmacological and pharmacological, this part will go quickly. And so really the non-pharmacological, I don't know necessarily if I should say it's treatment, I think it's more augmentation. We've already talked about exercise, but animal therapy, gardening, cooking, arts and crafts, all of these, again, with animal therapy, it helps us with regards to the depression or anxiety component, but doing things like taking care of grandchildren, keeping up after young kids, volunteering, again, it's just utilizing your mind. And even like music therapy has been seen. So this more so when I go over the music therapy component, it's incredible what that does, especially with folks who are more in the advanced cognitive impairment stages. Talked about mindfulness, based interventions and aromatherapy. Those are also some of the things I'm trying to utilize here on the unit. As they're giving me a lot of freedom to be able to kind of use more alternative methods to see if we can help improve cognition. But traditionally, there's other medications I'll go over real quick. But see, this is just more so kind of what music therapy has been able to do or intervene with. So there's definitely a lot of, evidence that's been found to help with regards to the mood and certainly as far as cognitive decline. Folks that we get here is most so because they have behavioral disturbances, a lot of agitation, combativeness, playing music, it's night and day that we see here on the unit. So we utilize a lot of music therapy here on the inpatient setting. And mindfulness, again, like I was talking about more so with regards to yoga and just really finding, just the center in essence to be able to be more calm, lessen that cortisol level, and really just finding that peaceful pause in the day So, so mindfulness-based interventions are, really starting to grow, if not already. It's been there, it's always been there, but more so I feel like in the community now, we're seeing more and more folks taking part in this. Tai Chi is incredible. And we're actually hoping to bring that in here as one of our adjunctive therapies, because Tai Chi has been so helpful in balance and in with regards to even just the centeredness that I was talking about. So these practices are really quite helpful. I like to use a lot of aromatherapy, as for those who have used it. It really can change the environment for you. This is not so much treatment per se for dementia. However, it can really help. Let's say if you have a loved one that's, quite agitated, maybe you can use some lavender or some Melissa oil, which is kind of a lemon balm. Those are some that have been, found to be helpful with regards to calming the individual who does have some agitation. Again, things to minimize the amount of medications that we need to use. I mentioned Melissa oil, so that's the one that has the most evidence, but you can see sandalwood oils and some others that can also be helpful as far as just, burning them, not so much ingestion, but more so in the sense of smelling them. And this is a little bit more kind of in detail as far as the different things. And I can certainly provide, these slides, to those who might be interested. But I just wanted to at least introduce some things that, presently, I know I'm trying to really utilize here in the unit to see if it might also help in addition to the medications that, I'm prescribing. So as far as medication, so we're all pretty familiar kind of, for those who've been, prescribing and such, but donepezil has been around for quite some time, or Aricept. That's kind of our first line. And with these medications, with donepezil, galantamine, and rivastigmine, these are effective in our mild to moderate stages of dementia or mild to moderate stages of cognitive decline. But donepezil can also help in the moderate to severe. With galantamine and rivastigmine, that's more so just still mild to moderate as far as treatment. When we get more into the more advanced or severe dementias, and that's when sometimes I'll add on some Namenda or memantine, which can certainly kind of help with regards to some of the behavioral disturbances. But ironically, it can also cause behavioral disturbances. So it's really just a matter of trying to know the patient and the individual to see what might help them most. But as with most of these medications, unfortunately, sometimes they get stopped because that nausea and vomiting just becomes so, just intolerable that those are really the only medications presently that we have available right now to help minimize. And the way I've been describing these medications now is it doesn't reverse or it doesn't give back memories that have been lost. What it does is it just enhances the cognitive, just speed and things like that on a day-to-day basis, so that, you're able to remember what you are going to get in the next room, things like that. Now, I did want to talk a little bit about aducanumab. This is kind of a lot on here, but aducanumab was just recently passed by the FDA. It was kind of rushed, so to say, in a lot of folks' opinions, this past June of 2021. And currently, the only available therapy that, essentially it can help target the underlying causes. It's that beta amyloid I was talking about earlier. So what aducanumab can do is essentially help, with those plaques and breaking them down and getting rid of them. But the trouble with this medication, when it first came out, the cost, as you can see highlighted down here, $56,000 a year. So unless you've got that money, our American population cannot afford this. And it is an infusion. So it's a monthly infusion for this first 6 months, and then there's a maintenance afterwards. But luckily, because Biogen, that's the company that came out with this. There's been so much critique, as far as the costs and whatnot. It's been decreased, so now you're only going to need to pay $28,000. So nonetheless, really Aducanib, I've actually not had much experience with this, so I did want to bring it up that at least this has been brought to the forefront, and I think as we see more and more folks who are on it, hopefully we'll get more of an idea if it really is helping modify the beta amyloid buildup or the plaques in our brain, if it can really help decrease that. But the cost, as you can see, is pretty outrageous. I wanted to just bring this up. So in case people always, kind of ask me, is there a book that you would recommend? This is the 36-Hour Day is a really good family guide for those, who are looking to kind of learn more about the disease if we're at that point. And this really kind of takes it through from the perspective of the individual who has dementia, but helps the loved one kind of understand. So this was a book recommended by one of my attendings when I was still in training, and I still continue to recommend this book. They're not giving me any money. I'm not advertising it. I'm just saying this is the one that even some folks and family members tell me that they've really benefited a lot by just reading this book. And so that's the conclusion of my lecture. This is my nanay, my mom's oldest or only sister. It's actually, she was diagnosed in her early 70s and was really my motivation to really move forward with what I do and study. She's actually turning 93 this May, so this is an old picture. But it's amazing what my cousin has done to be able to keep her at home. And she still remains at home. It's certainly a challenge, and she needs 24-hour care at home now, but the struggle is real. It's out there. And so hopefully there's a lot more folks who, want to band together to be able to help our elderly. And hopefully, again, the goal here was to kind of find ways to help minimize our risks. But certainly, we know what the statistics hold. I always tell everyone, and this is my little plug because I see this so much here, while if everyone is of sound mind, please guys, get your power of attorneys situated. Let your loved ones know what your wishes are, because that really helps, as we if this is something that needs to be dealt with. So anyhow, so that's all I have so far. I'm sorry if I went over on time, but I wanted to open up for questions.
Excellent presentation. Let me ask you, if anybody has questions, please, you have two ways to ask the question. You can either type your question in the chat line,
Okay.
or later on we'll open it up for the audience to give an audio questions. But when you're asking the question, please unmute your mic. And I'm going to stop sharing your slides here, Jean.
Okay.
Can you stop sharing your slides? Okay, great. So now we've got this gallery view, and those who want to ask questions, wait, go ahead and take over now.
Okay.
Let me start off with one question for Dr. Salcedo. By the way, excellent presentation, and is very, very good for our audience and very educational and timely too. The question I had is this genetic testing to predict dementia. Where are we in terms of predicting dementia, and is it worthwhile going through the genetic testing so that we can prepare ourselves?
Right. So, I mean, that's really kind of, a lot of questions that, we had gotten. So where are we? So it's kind of more so, at least what presented with the epsilon variant, that's what's being, ordered, so to say, in CSF, getting our, orders that way. But as far as it's really very individual. It's kind of like how, you asked, do I really want to know I have Huntington's, or will I get Huntington's disease? It's really, that's where it comes down to, because that's what a lot of, family members, especially the children, will ask. And I really think at that point, it is so very individual, as far as, is this something I want to know? Because I hear you want to be able to prepare for it. But sometimes, we've also seen and they become more depressed. And so it really is a difficult, thing that the family should really talk about to see.
There's some questions in the chat line,
Okay.
but I think Kunda, we had discussed this as far as the senior moment and dementia. You want to elaborate a little more on this? You already, I think she joined late, Kunda joined late.
Gotcha. Yeah. So the senior moments. So a lot of, so the ways to differentiate it. So let's say, you might have walked into a room and you've forgotten what it is that you wanted to get. I think we've all commonly done that, especially if you're not sleeping or, there's a lot of things that might have been happening that day when you have a lot of things on your mind. But the way to kind of differentiate is you eventually remember. Okay. But the main thing to be able to differentiate between is using the activities of daily living. Are we still able to be independent in those components? Are we still able to, manage our finances, things like that, kind of like, what I addressed earlier on. Yeah, I mean, occasionally we will just forget that word. It's going to be the tip of our tongue. And that's okay, as long as it's something that comes back to you eventually.
Any other questions? Please unmute your mic before you ask the question. I think there is a mic. Your mic is not muted here. We cannot hear you.
I have a follow-up question, Pramod.
Yes.
This senior moments. So when should one be concerned and go for evaluation if these sort of senior moments keep on happening?
Mm-hmm. Yeah, so oftentimes I'll start to see people show up because they just got lost, driving to the bank, and that's where you normally go to, or even like the grocery store, kind of the more, common places. And so those are the two, that and for instance, let's say you're noticing cooking. So things that you're normally used to on a day-to-day basis, but now it's becoming almost like a danger, so to say, because commonly some people will tell me, I burned, I think have all left food maybe on the stove, but how frequently are you doing that? And so, it's really a combination of things, because I know I didn't get to, touch on the other different types of dementias, but, when you already have, let's say, the risk factors, involved, for instance, high blood pressure, diabetes, or poorly controlled, if you already have those risk factors, then you start to still continue to see this, decline. That's when, I would recommend, just get the, initial screening test. That'll give us, a good idea, at least whether or not any further testing needs to be done. And that's just a little piece of paper, takes about 10-15 minutes that your doctor would be able to do with you.
Thank you.
Jane, you mentioned about the insomnia, and I'm so glad you stress so much on the insomnia. But can you comment a little bit on the naps in the afternoon? There's so much discussion going on. How important are the naps in the afternoon, and how long you should take the nap? Can you comment on that, please?
Sure. Yeah, good question. So I've not really seen per se like specifically what is the recommended time, but limiting it to an hour is kind of generally what I've seen. And really the nap times, you want to not have it too close to supper is one of the other patterns that I've seen too, because what that can do is alter your sleep pattern at night. So I would say take that cat nap maybe 1 o'clock or, something after lunch. It'll be invigorating. But anything past an hour is generally, sometimes I've seen not so great with that.
And other thing you elaborated a lot was isolation and loneliness. And we are seeing this in our senior community. We have been serving our homebound seniors for almost 2 years now. And during this COVID time, our volunteers could not go in and sit with them. They just delivered the food. But they are saying again and again, hey, we like your food, but we like more you're coming in and spending time with us. And that senior age, that 30-40 minutes of volunteers time was so well appreciated by the seniors. And of course, several of you have read this book together. Our present Surgeon General, Dr. Vivek Murthy, has written this excellent book on Together, which is about loneliness and isolation. It's become a very popular book.
Definitely,
Any other
especially in this
questions you all have?
I have a question. This is Bhrugu Shah from Memphis, Tennessee.
time.
I wonder if the overuse of technology has anything to do with the, because people seem to depend too much on making coffee in the morning to reminding to take the pills in the evening, for example. So does any research shows overuse of technology could be affecting the mental situation?
I think, gosh, probably Dr. Bill Yar can attest to that more so with his population. But I would say, within the geriatric population that I work with, we've actually been utilizing it more so to be helpful. You mentioned, with regards to medications, I've always, when we were working in an outpatient setting, would put those reminders of when to take meds. But I can't say for sure, as far as it actually negatively affecting it. Now, of course, I think my mom might beg to differ, as my dad spends a lot of time on his phone and Facebook, that sometimes maybe, but I think just the actual, time spent, I would think more so the things I've seen is maybe the blue light exposure to a lot of technology that can certainly affect, especially kind of our sleep wake cycle. I've definitely seen some, publications on that with regards to maybe just that excessive exposure. But I can't think off the top of my head if there's anything specific, that might. But certainly we're seeing an increase of that. Heck, that's how we're seeing our doctors these days now. So I'd be curious to see too, if there are, actual effects.
The
And I
human
say,
contact, the human contact is definitely more stimulating than electronic contact through the media. But I wanted to ask you one other question. You mentioned learning, lifelong learning as a way of maintaining cognitive skills. Is there any benefit for group learning as opposed to individual learning? Like we have group discussions on scriptural or church groups and whatever, but that group learning seemed to have some additional benefit compared to the individual study. Is there any evidence?
I'm not sure about the evidence, but I would imagine because of just kind of the social interaction and how that's beneficial, I would imagine that would definitely have a positive impact on that. And so I think that's what we're all craving, is to be able to do those types of things with it. So, but yeah, I'm not sure specifically, as far as the evidence on group, but I would imagine definitely helpful. And I did want to note too, kind of, how when we first were studying kind of what can help with dementia, we'll do crossword puzzles, do word searches, those are great, but they work on knowledge you already have. So really the encouragement is, learn to play a new instrument. I talked about learning a new language, learn how to play tennis or learn something new. And that's, essentially to try to really tap in on, the other neurons that are just, lying dormant. So I would say that would be, also where a lot of the articles and publications have been on.
There are some questions in the chat line. Go ahead. You have some questions. There are some questions in the chat line about the slides and the presentation. This is recorded, by the way. The whole session is recorded. And usually the recordings come out very well on the cloud. So if anybody is interested in getting a recording, please send me your email and I'll forward those recordings. And actually you'll enjoy the recordings very well and you can pass it on to your family or friends. There are a few other questions, Jean, on the chat line. Somebody is asking, is there a treatment for mild dementia? Great presentation.
Yes. So right now, when it's in the mild stages, what we've been using is the, well, donepezil is the one I usually start with, but when that's not tolerated, then I'll switch to rivastigmine sometimes. So those, the list of the medications, and I'd be happy to share the slides. I think I saw on there someone asking about that. Those are what's beneficial for mild. So, but when we get into the later stages, that's where we are a little more limited with regards to pharmacological treatments.
There's another question here. Could you please touch base with the executive function impairment? Great presentation.
Okay, yeah, and so really with a lot of the executive function, you know, on the MoCA, it makes me, so the MoCA is the Montreal Cognitive Assessment. Some people know about it because I think it was posted up there what President Trump had taken a test or something or other. I think this was some years back. So that's where I think MoCA gained its popularity. But from the clinical sense, we do evaluate that. And that's more along the lines of, that's when we ask the individual, you know, draw a clock for me. Let me see how your clock looks like, or, you know, kind of tracing. So with the executive function, that is one of the things that we do tend to see. I won't say 100% of the time, the earliest, but with executive function, that's when we really can start to see people actually declining, because it is that inability to plan, you know, or really kind of plan out the day, or really kind of the sequential, you know, components that we've seen. So I would say that's essentially what, at least clinically, that we would see or hear about from family members and individuals, because executive function is one of the earlier ones that you'll tend to see, whereas language is a little bit, you know, kind of later affected of those cognitive domains I was talking about earlier.
There's one more question. Is there data available on the rate of incidence by ethnicities, white, blacks, Asians, Americans?
Actually, yeah, no, that's a great question. So actually, if you look on the Alzheimers.org website, they actually just added it because they update this every year. They actually incorporated a racial kind of breakdown of what we're seeing, more so as far as like the incidents. But it also talks about too, you know, some percentages because of people of color, you know, essentially are more marginalized in the sense, you know, and wondering whether or not they'll get the treatment. So I would say, I don't know the numbers off the top of my head, but in review, actually, they had a really good section on there. So I would recommend going to, I think it's alzheimers.org is the website, but it's got that breakdown there.
There's one more question. Is turmeric, there's a lot of discussion about turmeric, but somebody is asking, is that helpful?
Yeah. Oh gosh, I'm a big fan of turmeric, ginger, anything really to decrease that inflammation, right? So, and even I mentioned earlier to the lady that was on earlier, I don't think she's on here anymore, you know, in that group session, we had discussions of ashwagandha, you know, I didn't even know about that, but the Indian ginseng, right? So you guys are probably know more a little bit about that. But I think the theory behind why turmeric has just really gained a lot more, I mean, it's been around for forever, right? But the reason I think it's really gained a lot more in popularity is because of its anti-inflammatory effects. And so as far as that, I would say, again, based on just the theory we're talking about, cortisol, right? If we can, you know, kind of just help minimize, you know, that inflammatory process, I would imagine that would be really helpful. And it tastes so good. So, that alone, I would highly recommend it.
I have a question. Can I?
Yeah, go ahead.
Yes. You know, in the list of medications that have adverse effects, the first one was antihistamine, and you mentioned Benadryl. Is there any safe antihistamine that does not have as much, or should you avoid long-term antihistamine use?
And I think you hit it the nail on the head. It's the long-term portion. So certainly we'll need, you know, a Benadryl here and there, but the long-term portion is really, I think, the point that, you know, that can worsen all of that. I would say, you know, kind of the ones, you know, your daytime, you know, the Allegras or, you know, the loratadines, the ones that don't have as much of that anticholinergic effect. Those would be ones I would go towards. But of course, the ones that are most beneficial, unfortunately, are the ones, you know, that hurt us more so when it comes to cognitive impairment. So that's a good
Thank you.
question. Of course.
Thank you.
Welcome.
You scared us by talking about statins contributing to dementia.
I know, I knew that would stir up some questions.
Because we Indians have a higher risk for heart disease, and they have been recommending to us to decrease our cholesterol levels, LDL levels, much lower than like 100 or lower,
Mhm.
and that requires higher dose of statins. And now, can you elaborate a little bit of exactly what would be your guideline about what's the highest
Yeah,
dose
no, I'm
of
not
statin that's
saying,
safe?
right, no, for sure. And so, I mean, I knew that would, you know, kind of stir up, like I said, because typically what they were talking about more so was the general component of what statins do, you know, kind of saying, well, not all cholesterols are bad. And so, but in that setting, when there is a higher risk, of course, of the heart disease, then that's what we've got to really modify. And so, but this is more along the lines of, you know, essentially, like you said, I mean, that is the challenge, you know, because that is going to be a part of long-term, you know, treatment. And it's just something to kind of be, you know, aware of, because I wouldn't necessarily say it's a risk factor per se, but it can certainly, you know, worsen, you know, cognitive impairment. So to me, you know, it's like that risk to benefit, you know, ratio. I think obviously the risks are in that situation much higher, that, you know, certainly the statin would be quite beneficial. Like you mentioned, you know, within the Indian population, and even in the African American population, you know, as well. So that's a tough one, though, right?
There's one other question I had about the Indian population. We tend to take care of our spouses. Sometimes spouses take care of spouses, and one person, especially a retired person, has nothing to do because his wife takes care of everything. Can that contribute to dementia? That kind of way of one
Right,
person
so-
taking care of the other person and not giving him any responsibilities.
I know,
or
right?
giving her.
You're
Yes.
challenging all the. I don't know if the husbands are going to be thankful for this.
Correct,
They are.
husbands and wives. One of them takes over and the other one becomes a dummy.
Hey, and exactly. Well, I didn't say dummy now, but no, certainly, you know, with it, you know, I don't have, you know, as far as like evidence-based to be able to kind of, you know, add to that, but it is curious that, you know, what I see is when the wives are first to go, the husbands don't last very long. And again, I'm sure there's probably specific research out there, but anecdotally, in the short time I've been doing this, it's guaranteed almost within a year. So I challenge the husbands out there to take on more. And that way you will still survive beyond that year after, God forbid, you know, your spouse dies. But no, I'm not sure as far as the evidence behind that. But yeah, I hear you though.
I have a question
Yeah, go ahead.
regarding antihistaminics. Because of allergies that I have,
Mhm.
my doctor has put me on single air. Now this is like benefit versus risk ratio, you know. If I don't take it, I get allergic reactions to anything in the world
Right.
twice a week. And then if I take it, what is the risk of getting dementia?
Sure. So think of it, I mean,